Learn about the important EEGs for our NEET PG, for INICET, and for FMGE exams. Alright, and these are the basic EEGs that they ask, and these are actually used during your practice also. So I know that complicated and complex EEGs will be reported by a neurologist, like we do that all the time, but some basic knowledge about EEGs is always good when you are handling patients, even in periphery or in a secondary care or in a tertiary care hospital. You should have an idea. So let's learn about that. Now, one thing is that sorry, one important thing here, that we need to know the EEG frequencies first, right? Now, what is an EEG? EEG stands for electroencephalogram. Electroencephalography is the procedure. Electroencephalogram is the graph that we get, like this one. Secondly, please remember that 1020 international electrode in 1020 system and international electrode system, there are two electrode placement systems. So 1020 system is the one that is used in India. Now by 1020 we mean that on the scalp, if we are placing the leads like this, frontal, temporal, parietal, occipital, then this is central, this is fronto-central, this is prefrontal. So if we place the leads like this, the distance between two electrodes will be 10, and then the next will be around 20, then it will be 10, and then it will be 20. So the 10-20 system, in the 10-20 system, the 10 and 20 refer to the distance between the two electrodes. So we'll try to remember that. Now this is the normal, these are the normal frequencies. There is a normal electrical discharge in the brain. So we do have a normal EEG also. All EEGs are not abnormal. So what is normal? We need to know what is normal. So there are different kinds of waveforms. For example, delta, theta, alpha, beta. I'm sure you must have heard about these. Now I have devised a mnemonic for you, D-tab. I remembered these frequencies with this only. So D-tab means D for delta, T for theta, A for alpha, B for beta, and then gamma you can remember, A, B, C karke gamma you can remember. So delta frequency is less than 4 Hertz. Theta frequency is 4 to 8 Hertz. Alpha is 8 to 13 Hertz, and because it is easy to remember as 13 to 30 rather than 14 to 30, I used to remember it like this, but the frequency is 14 to 30 Hertz. And anything more than 30 Hertz is gamma till 100. More than 100 we call it ripples. Okay, so these frequencies are usually not recorded in our scalp EEG. These frequencies are very high frequencies, usually not recorded except in certain situations. But here we need to remember D-tab. Okay, we need to remember this, D-tab. Delta, theta, alpha and beta, and please try to remember the frequencies. Now Hertz, what do we mean by Hertz? I think we all have read our physics, and Hertz means per second. Hertz means per second. Per second. So if this is the graph, and if I say that this is 1 second, my marking of 1 second is this. So this is 1 second. So how many waveforms are there in 1 second? 1, 2, 3, 4 and a half. So this graph is showing 4.5 waveforms, 4.5 waveforms per second of the graph. That means that the frequency is 4.5 Hertz. So this is what we mean when we say that this is the frequency, this is Hertz. We mean that these many waveforms are there per second. Now as you can see, when we go from delta to beta, the frequency keeps on increases. So beta is the one that we see in an awake, normal, alert, conscious state. Alpha is when we are relaxed or we are in a light meditation. Theta is when we when we are going from wakefulness to sleepiness, and delta is a deep sleep, our REM sleep, a deep sleep. So when a patient, as much alert as we are, we have a higher frequency. As we get more alert during the day, the frequency in the brain, EEG, keeps on increasing. The electrical impulses keep on increasing. So we'll try to remember this. Now this is the normal awake EEG and the normal waveforms in the EEG. We also need to know what are the normal EEG patterns in sleep cycles. So let's look at the sleep EEG. So when we are in an awake state, now I need you to focus over here. When we are in an awake state, we have a higher frequency. As you can see, we have a higher frequency. As we go on to stage 1, theta waves start, right? Theta waves start. And in stage 2, we have something known as a K complex and a sleep spindle. Now this K complex becomes important for you because this is what is asked in exam. K here stands for knocking. K here stands for knocking, like you knock someone awake, knocking awake. So this knocking awake is only to make you remember that the K spindle goes something like this, and then there is a high frequency. जैसे किसी ने उठा दिया, like we are sleeping and then we got alert immediately. So it is a K complex. A complex always has more than one waveform. So this is what they mean by a K complex, and it is seen in stage 2 NREM sleep. Stage 2 NREM sleep. So we'll try to remember this because this is something that is asked in exams. Sleep spindle is something that is like a spindle. It is shaped like a spindle. The waveform is shaped like a spindle. Sleep spindle and K complexes both are present in stage 2 NREM sleep. Now we'll learn about the various phases of sleep and polysomnography in this chapter on sleep. But for now, let us move on to the abnormal EEGs. Okay, so I'll put this out as a question to you. So you can try to think of the answer before I tell you about it. The question is that it is a 16-year-old girl with fever and seizures, altered behavior for 1 week. For 1 week, this is the MRI and this is the EEG. What will be the treatment? What is going to be the treatment? So let me explain this to you. It's a 16-year-old girl, fever, seizures, altered behavior. Fever, seizures, altered behavior. The triad tells me that it could be meningitis or it could be encephalitis, right? So, and it has been there for 1 week, which tells me that it may be pyogenic. It can surely be viral, and it may be tubercular. But in tubercular, the history is a little prolonged, right? Low-grade fever for a month or 2. And then patients present with meningeal features like neck stiffness and seizures. So this MRI, as you can see, is showing a temporal lobe hyperintensity, right? A temporal lobe involvement. Now we know of a virus that typically involves herpes simplex encephalitis. Beta encephalitis means that the brain parenchyma is involved. This is the virus that affects the temporal lobe. Right, so we now know that we have a hint in our mind that it can be herpes simplex. Now let's look at the EEG. The EEG is showing something known as PLEDs. Now what are PLEDs? PLEDs are periodic. Where should I write this? Okay, wait. Did not think of that. Okay, so this EEG is showing PLEDs. What are PLEDs? PLEDs are periodic, lateralized, epileptiform discharges. Periodic, lateralized, epileptiform discharges. Periodic means that the abnormal discharges are coming at a specific interval. For example, if you can see, this is the abnormal waveform. This is an epileptic form discharge. This is an epileptic form discharge. This is an epileptic form discharge, and they're coming periodically. So this is periodic. Lateralized. By lateralized we mean in the MRI also we can see the left side of the brain is involved. In the EEG also the left leads are involved. The right leads are all normal. And ED is for epileptic form discharges. So this is something known as PLETs and usually seen in herpes simplex. And now your answer is going to be acyclovir, injectable acyclovir. Right? Let's move on. Please take a screenshot. So the questions in the exam are not very tough. They are the questions that you have already read about. Right? You just need to apply whatever you have read about. You need to apply in the exam and you need to read the question carefully. I cannot overemphasize on this. You need to read your question carefully, word by word. Let's move on to the next EEG that we have. Okay, again, a case scenario for you. A 3-year-old child, a 3-year-old male child, a boy, having daydreaming, or episodes of behavioral arrest. So any of these words can be used in your questions. Behavioral arrest. So a child which the parent says that gum ho jata hai, he gets lost, he seems lost in his thoughts, or he daydreams a lot. Right? So what do you think of? You think of absence seizure. You think of absence seizure. Now the question is, what is the EEG showing? What is the EEG showing? So let's look at what the EEG is showing. So we can look at the markings here. These are the markings for 1 second. These are the markings for 1 second. Now as you can see, per second, 1 2 3 1 2 3 1 2 3 1 2 3. More clearly over here, 1 2 3 1 2 1 2 and 3 1 2 3, right? So 3 waveforms per second, which means 3 hertz epileptic form discharges involving all the leads. So generalized epileptic form discharges. This will be your answer. It's a 3 hertz generalized epileptic form discharges, and this is a child having absence seizure. So this is very importantly asked in an exam, a very important question, and a very frequently and a very old question actually. I think you all must be knowing this already. Let's move on to the next one, to our third abnormal EEGs. इसमें तो answer already is given. Okay. So, so this is the normal, these are normal waveforms, right? In this 1 second, 1 2 3 4 5 6 7 8 9 10 10 and a half. So 10.5 hertz normal background, right? And we know that 10.5 hertz is an alpha rhythm, so normal background. So this is a normal EEG, and here we see a chaotic background. What do you see? We see a chaotic background, even the background is chaotic, which means that there are polymorphic waveforms. Which means that waveforms with multiple formations or morphologies and more than 200 hertz frequency can be there intermittently, involving all the leads. This is a case of hypsarrhythmia. इसमें बेटा you are asked a very direct question. You're given an EEG and you're asked what is the EEG showing, and the answer is hypsarrhythmia. Now a little bit more about it. Usually seen in infants with spasms, Also seen in patients of tuberous sclerosis, also seen in patients of West syndrome. So these are the 2-3 things that you need to remember about hypsarrhythmia. Right now, childhood epilepsies are usually asked, so either a drug of choice will be asked, which we'll talk about when we talk about the anti-epileptics, and sometimes people also ask about the direct question about EEG, like what is the EEG showing? Okay, question for you again. A 15-year-old girl with myoclonic jerks drops objects, so they can say myoclonic jerks or they can say drops objects frequently, like brush, pen, pencil in school, right? Scholastic performance is okay. Scholastic performance is okay, not declined. Okay, so every word in this question matters. Why? Because the options are GME and SSPE. The options are GME, SSPE. Both have the same age group. Both can happen in girls. Both have myoclonic jerks. In both, the patients can drop objects frequently. But in JME, the scholastic performance, that means the mental ability or the development is okay. But in SSPE, the development is okay, but then there is a developmental delay. Right, so it is not like a developmental delay in children. All the developmental milestones are achieved, but around 11-12 years, the child starts performing not very well in school and starts, skipping homework and not able to do homework because of these jerks happening in the hand. So the scholastic performance dips. The scholastic performance dips. So SSPE, scholastic performance dip. So when they tell in your question that the scholastic performance is okay, this directly tells me that this can be a case of JME. Right? Now let's look at the EEG. What is this EEG showing? We know that this is somewhat a generalized epileptic form discharge, right? This is a generalized epileptic form discharge because it is involving all the leads. And it is a high frequency discharge, and these are polyspikes. Here we can see a wave, a spike and a wave, and polyspikes, right? So this, my friends, is a myoclonic jerk. This is a myoclonic jerk. This can also be seen in patients of GME because they also have GTCS. So this can also be seen there. But there, if it would have been a GTCS, the duration would have been a little longer. Right, so the duration of 1 second tells me that it can be a myoclonic jerk, simply a myoclonic jerk. Plus in the question it doesn't say that the patient is having seizures, but JME patients have GTCS too, and they usually present with GTCS. Myoclonic jerks के साथ वो present ही नहीं करते हैं, because myoclonic jerks are not something that take you down or take your performance down, but GTCS does. So that is something that they present with. So I hope you know now about SSPE and JME. In SSPE, we also find something known as the Rademacher complex. We can read about it later. Let's move on. So here we have triphasics. Now this slide is self-explanatory. Right, in triphasics, it means that there are 3 phases. By 3 phases, we mean a negative phase, a positive phase, and then again a negative phase. So there are 3 phases: a negative phase, positive, and a negative phase. So upward deviation is known as a negative phase, downward deviation is known as a positive phase. Now, triphasic waveforms are seen in any region of metabolic encephalopathy. Anything that comes in this category of metabolic encephalopathy will show you triphasics. For example, hepatic enceph. For example, uremic NCAF, even septic NCAF, even hyperammonemia. Wait, what is the chemical formula for ammonia? NH4. Right. So even hyperammonemia. So metabolic encephalopathy. Now look at the EEG. Can you see this? इसमें ज़्यादा अच्छा है ये वाला. देखो पॉजिटिव, नेगेटिव, पॉजिटिव एंड नेगेटिव, नेगेटिव, पॉजिटिव एंड नेगेटिव. See, these are good waveforms. These are good triphasic waveforms. These are good triphasic waveforms. You can try to remember these from here. These are good triphasic waveforms. Again, a negative, a positive, and then a slow negative. This is what a triphasic looks like. Now the question goes like a 60-year-old male with CLD having seizures or even not having seizures is having altered sensorium. A patient, a 60-year-old with CLD having altered sensorium. This is the EEG. What is the diagnosis? And the answer is usually hepatic NCAF in the question. So read the question carefully, read your options carefully. Now this we have already learned about in our Prion disease chapter. I think you must remember this now. So in this, the question will go something like a 60-year-old male with rapidly progressive dementia, with or without, so plus minus myoclonic jerks. What is the finding? This is the MRI. And what is the finding in the EEG? Right? Or what can you do in the CSF to diagnose or confirm your first differential according to this EEG and MRI? So any of these questions can be there. So better look. This is the MRI. Now in the MRI we can see that there is cortical ribboning. In the MRI there is cortical ribboning. You can see here. So there is a hyper-intense lesion. There is a hyper-intensity involving the cortex, the gyri, the cortex and the gyri. So it's like a, what do we call it? It's like a race moose pattern, or we can say a ribboning, a ribbon-like structure. So we call it ribboning, cortical ribboning. And for cortical ribboning, diffusion-weighted image is more sensitive than a FLAIR or a T2 image. So please remember this. And EEG is showing 1 Hertz PSWCs. Now what are PSWCs? Periodic slow wave complexes. Periodic slow wave complexes. So if you see here, look carefully. These one here, and also these, then these are the 1 Hertz. So why do we call it 1 Hertz? So this is 1 second, second number 2, second number 3, in every 1 second. So these are something known as a precursor of an abnormal EEG, but I need you to focus here on these waveforms. So these are the abnormal waveforms, and it is coming with a frequency of 1 per second, which means it has a frequency of 1 Hertz. So this is an EEG suggestive of a CJD patient, a Creutzfeldt-Jakob disease patient or a Prion disease patient. And in the CSF, the answer is 1433. 1433 protein is tested in the CSF for Prion disease. Now I have taught you Prion diseases in much detail in my another lecture, so please go through the lecture on Prion diseases. I've also mentioned all the MRI features and EEG features there in that chapter. Now moving on. Typical generalized epilepsy abnormal discharges are usually, the typical discharges are polyspike and wave. Right, so if you ask me what is a polyspike and wave, I want to show you. I don't know where did that EEG go, case here. We missed it, yes. So see, this is the best example of an abnormal EEG. This patient is having GTCS, a 23-year-old male having GTCS for last 1 year, once per month. What is the EEG showing? So this, I get this EEG only to show you how polyspike and wave look like. So see, a spike and a wave. A spike and a wave. The spike can be longer than the wave. The spike can be shorter than the wave, depending on the lead which we are recording on. Spike and a wave, a spike and a wave, right? So these are spike and wave discharges. What are these? These are spike and wave discharges. And because these are present in all the leads, so these are generalized spike and wave discharges usually seen in patients of idiopathic generalized epilepsy in this age group. 15 to 25 years में अगर आपको generalized epileptiform discharges मिल रहे हैं, it can be idiopathic. Or if there is something in the MRI, it can be that also. If you don't find anything on the genetic screening and the MRI, it is classified as an idiopathic generalized epilepsy. Now please remember that the abnormal epileptiform discharges, the 90% epileptiform discharges that are abnormal are usually having a slow frequency. So can you see here in this 1 second we have 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 waveforms, and here in this 1 second we have 1, 2.5. So this is a 2.5 hertz frequency and the voltage also. So if I tell you that this much is 10 microvolt, this will be more than 100 microvolt. So 100 to 250 microvolt. So large amplitude slow waves are usually abnormal epileptiform discharges, or they are usually normal slow waves. So then look for spikes and waves. Look for spikes and waveforms, because at your level you need to remember these things only. You need to catch the spike and wave discharges on the EEG. You need to catch Triphasics. You need to be able to tell about Hypsarrhythmia. You need to be able to tell about the frequency of the discharges. You need to know what is the normal frequency. You need to know that if a patient of CLD is coming in, you are sending him for an EEG, what are you expecting him to have? And these are the questions that are usually asked. This is the thing that is usually, sensed by the examiner, and these are the things he wants you to know. So please remember all of this. I hope the GTCS or the generalized discharges is very, very clear. We also talked about lateralized discharges, pleds in herpes simplex encephalitis. Now I'm not sure if there are more. So this is one thing that was asked once in INICET about 2 years back, I think, right? So this is a patient of, I'll tell you, this is a patient of so I can make a question scenario for you. A 21-year-old male with seizure activity for more than 5 minutes, or you can say that altered sensorium or unconscious for about 30 minutes. Anything more than 5 minutes, he came to the emergency department. He was loaded with AEDs, multiple AEDs, and now this is the EEG. After loading the AEDs, anti-epileptic drugs, AEDs, anti-epileptic drugs, this is the EEG. So what is the EEG showing? So this is something that we aim for in this patient. Now the patient is having seizure more than 5 minutes. So patient is in status epilepticus. So because status epilepticus की बात हो रही है, you need to remember that table or the algorithm that is shown for treatment of status epilepticus, because it is a very simple graph, but a very simple flow chart, but a very, very important one for you at this level, asked in MCQs, asked in your prof exams. So please try to remember that Harrison table also. I will also try to cover that topic when I talk about anti-epileptics. But right now, because this is the topic on EEG, I wanted to show you this because this has been asked once. So this is something that we aim for when we give AED. So this is known as a burst and this is suppression. So it is a burst suppression pattern. It is a burst suppression pattern. It is a burst suppression pattern. Please remember this. So it is a burst suppression, burst suppression, a burst and a suppression pattern, right? So in the burst you have epileptiform discharges. In the suppression you don't have any discharges. The baseline is having a very low frequency but no large amplitude waveforms. So burst suppression pattern is seen in status epilepticus. Please try to remember this. So that's all about EEGs. I hope you got the gist. These are the EEGs that have been asked till date, and these are the EEGs that can potentially be asked again also, because these are the simple topics that are usually asked. So please try to remember these. If there is more that you want to know about EEGs, because see, I'm a neurologist and I have done my DM in neurology, so we have a very vast knowledge about EEGs. We have read bigger books on EEGs. But for you at this level, this much is okay. But if you want to learn more, do let me know, because I can teach you more about EEG too. So we can have 2 to 3 classes on EEG, or we can have one workshop on EEG where we can discuss all the EEG waveforms and morphologies in detail. So do let me know, and all